I welcome you all to the CME program of the 19th Phanindranath Anesthesia Update and Anesthesia Postgraduate Academic Program, organized by the Department of Anaesthesiology, Kasturba Medical College, Manipal. We are honored to have distinguished speakers, postgraduate students, and practitioners from all around the country and abroad joining us. A warm welcome to all the delegates and the speakers. Without further delay, we will begin with the first lecture. I am delighted to invite the first speaker for the day, our very own beloved faculty, Dr. ANITHA SHENOY. Dr. ANITHA SHENOY is a professor and has served as HOD in the Department of Anaesthesiology at Kasturba Medical College, Manipal, with more than 35 years of teaching experience. She has more than 75 publications in both national and international journals. Over to you, ma'am.
Good morning, everybody. It gives me great pleasure to be the opening batsman of APGAP 2024. Coming to my talk, the heart is probably the only organ that starts beating right from the womb to the tomb. And with each beat, we are all familiar that there are a lot of events that go on in the heart. Very interesting. So we are all familiar with the depiction of these cardiac events in the form of pressure time curve and volume time curve. But then what happens if we pitch the pressure against volume, and that is when you get the pressure volume loop. So this is a pressure volume loop in construction. You have the volume on the x-axis and pressure on the y-axis. And let's start plotting the events. So the first thing we would start with is the diastole. The mitral valve opens, and when mitral valve opens, you have blood gushing in from the left atrium into the left ventricle. The last part of this diastolic filling is going to be enhanced because of the atrial systole, and there's going to be an increase in volume because of that. So that's the last part you can see, and then once the filling is over, the mitral valve closes. Following which you have contraction, because filling is done and then you have the systole starting. So with the systole, the tone in the ventricular muscle is going to increase tremendously. However, initially there is no change in volume, it is only change in pressure, and we call this phase isometric contraction phase. This goes on till the point the pressure inside the ventricle is over and above that of aorta, and then the aortic valve opens. So that is the isometric contraction phase, which ends with the aortic valve opening. And once the aortic valve opens, there is a sudden gush of blood into the peripheries. Initially it is going to be fast, so that is called rapid ejection phase, and once the gradient is lesser, the ejection is going to slow down, the slow ejection phase. And at the end of this ejection, the aortic valve is going to close. This happens when the aortic ventricular pressure is going to be lower than the aortic pressure. And so that's the next phase, that's the ejection phase. This, once the ejection is over, then the ventricle has to relax again, and the ventricle is going to reduce its tone tremendously again with no change in volume initially, and that's called the isometric relaxation phase. And these phases form the pressure volume loop of the left ventricle. So what do we do with this PV loop? What is the information we get? Let us see. So we know what is the end systolic pressure. Okay. We know what is the end systolic volume. We know what is the end diastolic volume and also the pressure. And the difference between the end systolic volume and end diastolic volume would be the stroke volume, and the stroke volume as a fraction of the total stroke volume as a fraction of the end diastolic volume would be the ejection fraction. Okay. Right. What else do we know? You can also look at the effect of preload on the pressure volume loop. If you look at this pressure volume loop, okay, you can see that as the middle one is depicting the normal pressure volume loop. When the preload increases, we know from Starling's law the fiber length is increased, the contractility is going to be more, and so you get larger amount of ejection from this, and so you can see increased preload, you get a larger pressure volume loop. If the patient's preload is less, the pressure volume loop is going to be smaller and it just shifted to the left. So that's how it's going to look like. However, there's something called the end systolic pressure volume relationship end diastolic pressure volume relationship, these lines are going to remain the same with just the change in preload. I will explain further a little more later. So, what is preload? Preload is a filling of the ventricle at the end of diastole, but you can calculate it in this form. Preload is equal to left ventricular end diastolic pressure that you get from the pressure volume loop. Left ventricular end diastolic, forgot what that was, radius, sorry, divided by 2h, that is the thickness. Oh, it is written here also, third block. Okay, what happens with the effect of change in contractility? So, you can see that the pink one is the normal one, and if there is loss of inotropy, you can see that it shifts to the right, and it also goes this way. You can see end systolic pressure volume relationship, it has shifted to the right and downwards. Okay. And that relationship is also called end systolic elastance. You can remember that name, end systolic elastance. Okay, there is a term called arterial elastance. You can see that this is the end diastolic volume here. The end systolic pressure that you get with that end diastolic volume with the same amount of contractility, you can see that is the point. The line joining these two, that would depict what is called the arterial elastance, and that tells you what is the status of the arteries, peripheral arteries. So, if you can see, if there is effect of change in afterload, if you see that if there is an increase in afterload, if the left one is the normal pressure volume loop, you can see that the ventricle has to create or generate so much more pressure to eject the volume outside. So, you get a higher systolic pressure for the same contractility, and so you call it, there is higher arterial elastance. You can see that the line has shifted to the right. The end diastolic volume is actually the same, it is only a change in afterload, so you get a higher systolic pressure. So, that is what you would find. The middle one is a normal one, with an increase in afterload, you find that the pressure volume loop changes like this, and if there is decrease in afterload, it shifts to the left like this. But see, the end systolic pressure volume relationship and the end diastolic volume relationship have not changed. Just to revise, the black one is a normal one. If you give esmolol, that is reduction in contractility, you can see that the end systolic pressure volume relationship has moved downwards and to the right, and the stroke volume is actually reduced. Whereas, if you give dobutamine, you can see there is an increase in contractility and shifted to the left. Afterload changes, you can see the black one is the normal one. If there is an increase in afterload, say because of phenylephrine, that is going to change like this. Whereas, with nitroprusside, if the afterload decreases, you find that the arterial elastance is actually decreased, the slope has decreased, and it is moved to the left. Okay, so about the heart, it is not just contractility, the lusitropy or the relaxation characteristic is also very important, and earlier we used to look at what is called the dP by dt, the increase in the way dP, not this, dP by dt, the way the pressure changes with time, the way it relaxes would tell us about lusitropy. And if the ventricle is not relaxing very well, you will find that it takes a little longer to relax. So, this is a normal ventricle, 30 milliseconds, but if it is relaxing not so well, if it is a stiff ventricle, it would take longer, 80 milliseconds. In the pressure volume loop, in the lower part of the curve, you can see that if this is the normal end diastolic pressure volume relationship, if there is increased stiffness, diastolic dysfunction, you find that it shifts upwards and leftwards, that is end diastolic pressure goes up, whereas if a compliant ventricle, you will find that it shifts to the right. So, this is the same thing, ventricular diastolic dysfunction, this is what would happen. This is the normal one is the black one, and the reddish one is the reduced one, and you can see the end diastolic pressure volume relationship has moved upwards. Okay, dilated cardiomyopathy, you can see that the normal curve has actually shifted to the right. Yeah, so just to revise, if this is the middle one is the normal one, in systolic heart failure, you can see that the end systolic pressure volume relationship has moved to the right, and in a diastolic heart failure, it is this part that is changing, that is the relationship has moved to the left. Okay. What else can we know from pressure volume loop? The area inside this loop indicates stroke work. There is the amount of myocardium work that is happening. Why does the myocardium need oxygen? It needs for basal metabolism, calcium cycling, actin myosin uncoupling, and for contractility. So, when contractility goes up, the oxygen consumption goes up, and you can see that from the pressure volume area of the inside the loop. Okay. This I am sure all of you know, you have to know pressure volume loops in valvular heart disease. Mitral stenosis, you know the left ventricle is essentially normal, but it is generally underfilled. So, it will look very normal, but it is smaller and is shifted to the left. So, this is what you would find, the end systolic volume and diastolic volume, they are all smaller, and stroke volume also could be lower because of the lower filling. Mitral regurgitation, you can find that there is a lot of blood going in and out of the left ventricle, and so there is a lot more work being done. So, you can see there is a larger loop here, and you may also not have the isometric contraction phase or even the relaxation phase, because it is moving in and out, and the pressure reached will be lower. Aortic stenosis, you can find that there is so much work against the afterload that is created because of aortic stenosis. So much more pressure has to be created, and the loop is going to change like this. Left ventricular end diastolic pressure is going to be higher as well. The area inside may or may not be larger, depends on how well the ventricle is contracting. Aortic regurgitation, again you find that there is no isometric relaxation phase, the blood is going to just come back into the left ventricle with contraction, and is much larger. So, a lot more volume work, we call it dilated hypertrophy. Okay. Anything else? So, pressure volume loops and cardiac interventions. Now, this is coming in a bigger way these days. So, you can find that if the pressure volume loop in the black one is the normal one, you can find that after percutaneous intervention in this particular heart, the first thing that the heart recovers is the diastolic function, and you can see that it is actually shifted downwards in this particular case after the PCI. This is a case of heart failure with preserved ejection fraction. So, that is a black loop, and you can see you can increase afterload by just giving a hand grip maneuver. You get angry, you tighten your hand, so that way hand grip maneuver, and you find that these patients with heart failure with preserved ejection fraction, they will not tolerate any increase in afterload, and you can see when that with that maneuver, it's the end diastolic pressure volume relationship is actually gone up there, and that is a diagnostic feature. This is application of mitra clip for mitral incompetence. You can find the black one depicts the normal, baseline pressure volume loop in that patient. Once a clip is applied for the mitral incompetence, now the regurgitation is going to reduce, and the patient is slowly starting to have isometric contraction phase. This is after transaortic valve replacement. Transcatheter aortic valve replacement, the red one is the abnormal one, and after replacement you can see that it is actually shifted to the left and the contractility is better. Intra-aortic balloon pump, you can see this is before the pump is applied, and then once a pump is applied you can find that this balloon augmentation of the diastolic pressure. Okay, so this pressure volume loop, the red one is the one with the IABP off, the blue one is with the IABP on, the heart is beating better. So, it also looks sophisticated, it can get more sophisticated, they have very accurate and reliable catheters, they can place through the aorta or through the septum, and they can have pressure volume loops for each segment of the ventricle. That is how advanced things are getting. Right, we were talking about left ventricle so far. Can we have a pressure volume loop for the right ventricle? Yes, you can, but remember the end diastolic pressure volume relationship is the same, but the pressures reached will be much lower because that is enough for the right ventricle. What about atrium? Atrium also can have a pressure volume loop. You can see that it has two loops, it looks like a 8. And if you start with the mitral valve closure and then aortic valve opening, and it is about ejection phase. During ejection, the AV valves actually go down, and so the pressure in the atrium is going to go down, but then slowly the atria will fill because of the venous return and the pressure goes up there. till such time the mitral valve opens, and then there is a sudden fall in the atrial pressure. The last part of the diastolic filling, as we said, is because of atrial systole, and you can find there is an increase in the atrial pressure. So, that is how it is going to look like, a H shaped, and that is the atrial systole here. So, the atria behave in different manners. It is a conduit for blood, it is also a reservoir of blood, and when the atrial systole, it is also a booster pump for filling. So, all these can be judged. Now, I am just summarizing the clinical applications of pressure volume loop. So, they can use it for percutaneous revascularization, transcatheter aortic valve implantation, percutaneous edge-to-edge mitral repair, heart failure diagnosis and treatment, cardiac resynchronization therapy, ventricular reconstruction, partitioning, mechanical circulatory support, and also in the assessment of repair of congenital heart disease. If you thought, oh, it's going to be very invasive and it's going to be difficult to get all this for day-to-day work, they're already working on non-invasive assessment of all this. So, this is estimation of left ventricular and systolic elastance from brachial pressure waveform via deep learning. So, I won't be surprised in the many years to come, it's possible that in addition to blood pressure, heart rate, ECG, etc., you in a sick patient especially, you may be actually monitoring pressure volume loops of the patients. However, do not get disheartened. As an anesthesia PG taking exams, this is what you should definitely be able to do. So, you should be able to draw a proper pressure volume loop, which would include 4 points. The 4 points would be mitral valve opening, mitral valve closure, aortic valve opening, aortic valve closure. 4 phases, that is going to be diastolic filling, isovolumic contraction, systolic ejection, isovolumetric relaxation. 3 volumes you can depict, that is going to be end systolic volume and diastolic volume and the stroke volume. 3 blood pressures, diastolic blood pressure here, systolic blood pressure and systolic blood pressure. The 3 lines you can see, end systolic pressure volume relationship, end diastolic pressure volume relationship, and the arterial elastance for the afterload. 2 works, stroke work, and this stroke work, if this loop is actually projected backwards to 0, you get the potential work that is done by the myocardium. So, this much information you can get from a pressure volume loop. You write that and you get your full marks. But often your question will also contain, draw the pressure volume loop in this valvular heart disease or that valvular heart disease. So, you can see how these are. You should be able to draw these for whichever valvular heart disease they have asked you about. So, we have our own ways of remembering things. So, mitral stenosis, I just remember is a tile, it's just a smaller tile than the normal one. For mitral regurgitation, I remember a pebble, that's how it looks like. Mango for aortic regurgitation, and for some reason it reminds me of Stonehenge, the aortic stenosis. So, I think in the past few minutes I have told you about the normal pressure volume loop and how it looks like in different valvular heart diseases, how it can be used for clinical purposes by the cardiologist and how sophisticated it is becoming, and then of course as postgraduates what you should be knowing when you take up the exams. Thank you very much.
Thank you, ma'am, for the detailed lecture about decoding cardiac loops. We shall now move on to the next session. The topic will be open for discussion at the end of the first 3 lectures. Next, we have a lecture by Dr. SADASIVAN D IYER, who is leading the pain management team at Manipal Hospital in Bengaluru. He is the founding member of the Society of Integrated Pain and Palliative Care and Musculoskeletal Ultrasound and Pain Society. He has also received Fanindranath Tota Gold Medal Award for the Best Outgoing Postgraduate in Anesthesia KMC Manipal from the batch of 2011. Over to you, sir.
At the outset, thank you all. Thank you. It's very hard to say thank you to your own family, right? You've grown up here. Whatever I've achieved in my life has come in from here. And so it is very overwhelming and a very emotional moment for me to be called back here to speak on a topic that is very dear to me, which is pain. I know it can be quite a pain to listen to someone talking in the morning on pain, but it is a very, very overwhelming moment, and thank you the Manipal Anesthesia family for having me here And I must admit, you know, in a year I do about 15-20 talks. This is probably the most nervous that I've been in any talk, right? I was ANITHA ma'am's student. She was my guide. And to follow her for a talk, especially when she's completed 7 minutes before the scheduled time, you can imagine what I'm going through, right? So yeah, so ANITHA ma'am still continues to help me by giving me a little more time to talk. But at the outset, thank you once again. So we'll talk on a subject that is one definite 10-mark question which can come in any of your 4 papers, usually paper 1, right? You're very unlucky that if you get it in any of your other papers, but usually you will have one question on pain management in paper 1, and consider yourself extremely lucky if the question happens to be on acute pain, because there is only so much that they can ask you on acute pain, right? If they go into clinical syndromes, then it's a different ballgame because you may or may not have seen those conditions. But this is theory, this is physiology, this is something all of you know. So what is pain? So pain is the most primitive of all human emotion, right? All of us feel pain. It's a very subjective experience. What I may perceive as pain may not be pain to you. It's influenced by multiple factors. Initially, pain is protective, right? But later on, as it becomes chronic, it becomes a problem. And it is the only sensation to have had multiple specialties treat it, all by different methods and all with different results. So we call pain a biopsychosocial phenomenon. So what do I mean by a biopsychosocial phenomenon? Your cause for pain could be social reasons, some of which may be in your control, some may not be in your control. Some could be biological, like listening to this guy talk early in the morning on pain. And for some it could be social, where existence in itself can be quite a pain. And we are talking of terminally ill cancer patients who go through a great ordeal to pull through every single day. Pain is a very subjective phenomenon, but at the same time there is a significant objective value to it as well. So in all, pain is what the patient says hurts. Unfortunately, this is not the answer that you can write for your exam. You will get 0 marks. So you will have to mug up this definition, which was released by the International Association for the Study of Pain. They have done 3 revisions so far, and the last revision has happened in 2020. And they have defined pain very clearly as an unpleasant, emotional and sensory experience which is associated with or resembling that with actual or potential tissue damage. And this updated definition talks on the perception of pain by the sufferer rather than a neutral third person who may or may not be able to perceive that emotion, the same degree of pain as the sufferer is undergoing. So this is something you must know. Even if you mug it up for your exam, you don't want to do pain thereafter, mug it up for your exam, vomit it in the answer paper and be done with it. So from when do we start feeling pain? We start feeling pain, or rather the development of pain and pain related structures start as early as 7 weeks, where there is development of free nerve endings. By 18 weeks, there is a hormone or a stress response to pain that happens. By 20 to 30 weeks, your neural mapping is fairly well established, right? And by 26 weeks, you start developing the hemodynamic and behavioral reactions to pain. So a 28-week preterm child can perceive pain if subjected to surgery or to any other painful stimulus, right? So managing pain is very important across all age spectrums. You may say, people saying, what will a small child feel pain. No, the child also will feel pain, right? So how do we classify pain? So there are multiple ways of classifying. I am really not going to go into all these details. This you will find in most books, and I'm sure most of you know how this classification works, right? But for today's lecture, let's look at two major classifications. One is depending upon duration. If pain less than 3 months, we call that acute pain. Anything more than 3 months, we call that chronic. Okay? Acute pain is protective, chronic pain is pathological. Acute pain is physiological, chronic pain is non-physiological. Usually the cause for the acute pain is some form of noxious stimulus, either in the form of an injury, and it is almost always nociceptive. However, there is an exception to this, or rather there are multiple exceptions to this, but in 8 out of 10 cases you will find that the cause for acute pain is some nociceptive stimulus. It serves to detect, localize and limit tissue damage, therefore it is protective, okay? And it is associated with a neuroendocrine stress response, which is almost always proportional to the intensity or the degree of stimulus. Chronic pain is pathological. It lasts beyond the period of healing and affects 20% of the patient worldwide. It may arise with or without any injury in itself and can be quite debilitating, impacting the quality of life in patients, and it is basically it's a burden to the society. You also have another way of classifying pain as fast pain and slow pain. Fast pain is pain that is conducted by the A delta fibers, which are myelinated, finely myelinated, therefore have a faster rate of conduction. Slow pain is what is conducted by the unmyelinated C fibers, which have rather a fiber diameter of less than 2 microns. This A delta fibers carry rapid pain, so therefore they are responsible for perception of pricking well localized pain, whereas C fibers conduct slow, dull, diffuse aching pain. The A delta fibers synapse in lamina 1 and 5 of the spinal cord, whereas C fibers synapse in lamina 2, which is the substantia gelatinosa of the spinal cord. Now, another way of classifying pain is the mechanistic classification, which is based on the mechanism of pain. So you have 3 types. One is nociceptive pain, which is occurring because of some form of tissue injury. The most classical example is our post-operative surgical pain. The second type is neuropathic pain, where there is some form of disturbance in the somatosensory nervous system, either in the peripheral nervous system or in the central nervous system. A very common example is an acute low back pain with radiation to the legs, or lumbar radiculopathy, something that we all see very often. Post-herpetic neuralgia, example of neuropathic pain. Now, there is a third type of pain called nociplastic pain. Now, what is nociplasticity? Nociplasticity is the phenomenon where there is an altered perception of pain with or without any stimulus. So, you can have pain without any damage. This pain is not going to be localized, will not have a referral pattern, will be very diffuse, and most importantly will be chronic. So, this phenomenon is called nociplasticity and is very commonly seen in a clinical condition called fibromyalgia. So, I am sure all of you may have seen patients with fibromyalgia, and this is the reason why they have pain. There is no tissue injury. So, you subject them to 100 scans, 300 MRIs, 400 blood tests, all of them are going to come back as normal, because the problem lies here and not in the periphery. Coming to the pathway of pain, how do we process pain? Right? So, pain processing involves 4 major steps: transduction, conduction and modulation. A combination of the 3 is what we all know as nociception. So, nociception is nothing but the neural networking that takes place when a body is exposed to some form of noxious stimuli. Now, this nociception need not result in necessarily you feeling pain. So if your girlfriend or your wife lovingly strokes your hand, you will not perceive that as pain, whereas she is actually causing some form of injury to your tissue. Whereas if your teacher does that to you, will be very, very painful, trust me on it, right? Or if your ex happens to hit you, right, it will be very painful. So that is because there is a fourth component of pain called perception of pain. And this perception of pain takes place in the cortex. Okay? So all the four processes are important for one to perceive and appreciate pain. First is transduction. Transduction is when any form of energy gets converted to some other form of energy. So when it comes to pain, it is conversion of this either mechanical, chemical, thermal stimulus that is happening on your body to an electrical signal that is getting transmitted across from the periphery to your central nervous system. Okay? And we all know that you have the A delta and C fibers, most importantly for causing this transduction of pain. Now, apart from the nerves, there is a inflammatory soup that takes place when there is a tissue damage happening. Okay? And this inflammatory soup, other than coffee and tea, you can write anything under the sun, you will probably be right. Okay? So there are a lot of chemical substances, CGMP, I myself don't know, CAMP, CGMP, nitric oxide, I can't even read it, the font is so small, right? Then there are role of C fibers which secrete two important neurotransmitters. One is calcitonin gene related peptide, which is this one. This is also thinking I'm a pain, it's not moving. Okay? So CGRP is one and substance P. So these are two very important neurotransmitters or chemical substances which help in modulating pain. Apart from that, there is enzyme activation, there is activation of TRP receptors, and most importantly, when this continues over a period of time, it results in activation of silent nociceptors. So this is responsible for development of the chronicity of pain. The same slide that we spoke about. Now, the receptors that are responsible for perceiving pain are called nociceptors. Okay? And these receptors are basically free nerve endings, okay, which respond to a variety of stimulus. It could be heat, cold, right, mechanical distortion, changes in pH, anything. And depending upon where they are located, you can classify them as cutaneous nociceptors, visceral nociceptors, and deep somatic nociceptors coming in from your muscles and bones. So we have a wide variety of neurotransmitters, some of which are excitatory, which help in facilitation of pain, which means help in feeling more pain. Some of which are good, which are inhibitory. They help in reducing the pain response. Okay? So we have a decent balance of facilitatory and inhibitory neurotransmitters in your body. The next step is conduction. What is conduction? It is relaying this nociception from the site of injury or from the periphery to the central nervous system, either the brain or the spinal cord. And the process by which the action potential that is generated from the periphery to the central nervous system is called transmission. How many of you need this lecture at this point of time? Good, thank you. Right. So one of the things that comes in conduction is the pathway of pain, right? So we all know that whenever there is a tissue injury, there is release of these neurotransmitters which can cause activation of this nociceptor, and this signal is then conducted to the dorsal root ganglia. Now the dorsal root ganglia carries the first order neurons which travel from the dorsal root ganglia to the spinal cord. Now in the spinal cord we have 3 layers. So the spinal cord is divided into 10 laminae. This was devised by Rexet. So lamina 1, 2 and 5 are responsible for pain conduction. So from the lamina 2 or lamina 5, you have second order neurons that move to the contralateral side of the spinal cord and ascend upwards as multiple tracts, but the most important of which we all know is the spinothalamic tract. This spinothalamic tract goes up to the thalamus, from where you have third order neurons which gets projected to the cortex and the subcortical region. The cortical regions we all know helps in perceiving the pain, and the subcortical region is responsible for the emotional control or emotional regulation of pain. This is something that we've spoken about. So the 10 laminae of the spinal cord, and lamina 1, 2 and 5 are responsible for pain conduction. The second order neurons, like I said, come in from the dorsal root ganglia, cross the contralateral side of the spinal cord and travel up as multiple pathways. So you have the spinothalamic, spinoreticular, spinomesencephalic and the spinobrachial pathway. The spinothalamic tract is basically, there are two tracts. One is the neospinothalamic tract or the lateral spinothalamic tract, and there is a paleospinothalamic tract or the medial spinothalamic tract. The neospinothalamic tract basically carries the discriminative aspects of pain, such as location, intensity and stimulus and duration, right? Whereas the medial spinothalamic tract or the paleospinothalamic tract is responsible for mediating the autonomic and emotional aspects of pain. They also project to the periaqueductal gray matter, which is responsible for modulating the pain, okay? And they send fibers to the reticular activating system, which is why when you are in acute pain, you will say patients will tell you that they are not able to see, your RAS is constantly being bombarded. Then you have the spinoreticular pathway, which is responsible for the arousal and the autonomic response to pain. You have the spinomesencephalic and the spinobrachial pathway. Now, when you talk of facial pain, there is a little bit of change. Your relay point here is the dorsal root ganglia. And the dorsal root ganglia in the face lies at the trigeminal nerve or the trigeminal ganglion or the Gazerian ganglion, right? Yeah, it's there, right? From here you have fibers going to the medulla in the trigeminal nucleus, and from there you have fibers crossing over to the opposite side and relaying to the sensory cortex. So this is a facial pain is a slight example where the pathway takes a little bit of deviation, but your final destination is still your somatosensory cortex. The third order neurons basically start from the thalamus and go on to the somatosensory cortex. You have projections going to the cortex as well as the subcortical region. The cortical region are responsible for the perception of pain and the subcortical regions for the emotional regulation of pain. So these are all the areas. You can see some areas are purely sensory, some are mixed emotional, okay, and you have three regions which are responsible for modulation of pain. Now, modulation of pain can either be facilitation or inhibition, okay, and you can have it happening peripherally or centrally. Peripheral modulation is also something that we all know as sensitization. That is, following repeated stimulation, the nerves become more sensitive, okay. It could be an enhanced response to a noxious stimulus or a newly acquired responsiveness to a wider range of non-painful stimuli. Consequently, you can have something called a primary hyperalgesia or a secondary hyperalgesia. A primary hyperalgesia occurs because of local release of inflammatory mediators and results in increased sensitivity in damaged tissues. Whereas secondary hyperalgesia is neurogenic inflammation manifested by the triple response of Lewis, resulting in a lot of edema, which happens not only in the area of damaged tissue, but also in the surrounding undamaged tissue. Can you have sensitization happening centrally? Yes, it can also happen at the level of the spinal cord and can happen at the level of the brain. Centrally, this pain can also be modulated, okay, where it can be facilitated or inhibited. facilitation by the descending pathway is not very important, doesn't hold a major role. But what is important is the descending inhibition pathway, which can happen at the level of the spinal cord, which forms the basis of your gate control theory, or can happen at the level of the brain, where you have output coming in from the periaqueductal gray, rostroventral medulla. All of them are either serotonergic or epinephric fibers, which reduce the intensity of pain that is felt. Okay? And it is also the site of antidepressants then when we use them for pain management. Okay, so the PAG and the RVM regions, we have gone through this. I am not going into more details. The important thing about the periaqueductal gray is also the site for action of endogenous opioids. So it produces the endogenous opioids, which is your enkephalin, dynorphin. All these are produced in the periaqueductal gray, which help in reducing the pain that is felt. Okay. The RVM basically has three cells, which have the on cells, off cells, and the neutral cells. The on cells exit an inhibitory effect. The off cells exit a facilitatory effect, and the neutral cells do a bit of both when this one. Consequences of acute pain, we all know. I don't have to teach you this. This is, you can have multiple pathologies as a result of which you can have a poorly functioning patient, or you can have a patient going into chronic pain. What are the theories associated with pain? So you have to know three important theories. One is gate control, the neuromatrix, and the endogenous pain control system. The gate control theory was proposed by Melzack and Wall in 1965 and says that there is a gating mechanism which can control the pain that is felt. So whenever you have pain that is felt because of some form of tissue injury, right? So what happens is these pain fibers, sensation are conducted by the A delta and C fibers to the brain and the spinal cord. Now when you do a massage, preferentially A beta fibers are activated, and at the dorsal horn of the spinal cord, the A beta fibers are preferentially conducted up to the brain, and there are inhibitory neurons that are activated which inhibit the transmission of the painful stimulus to the brain, which is why when we get hurt, the first thing that we do is a massage. Okay. So the three main gates are at the substantia gelatinosa. There is a gate at this level of the brainstem, and there is one at the level of the thalamus. What are the applications? One is heat and cold applications. We've spoken about massage. Okay. Dry needling, very useful technique for managing acute muscular pains. Okay. Acupuncture, and whenever you have motion sickness, most of the time you see you tend to do this, right? Because this again will stimulate the A beta fibers, and therefore through the trigeminal nerves reduce the sensation of motion sickness. The pain control system basically talks of endogenous opioids that are produced at the level of the periaqueductal gray matter. Okay. And they are responsible for inhibition of pain basically by reducing the reuptake of norepinephrine. And lastly, the neuromatrix theory. The neuromatrix theory says that pain is a very complex phenomenon. It is not just, just a perception of a response to a damaged tissue. Okay? It's not a passive response, but it's an active response. And it's a very subjective phenomenon, okay, and it is influenced by multiple cognitive events and other sensory influences. What are the drugs? When we use drugs to treat pain, what are the sites? So you see all our local anesthetics, NSAIDs act peripherally, local anesthetics, alpha 2 agonists act at the level of spinal cords, gabapentin, NSAIDs again act at the level of the ascending tracts, and the TCAs and SNRIs act on the descending modulating system. Thank you so much for a patient listening, and I'd like to take a minute to thank my wife and my daughter. They've never attended any of my lectures, but this is the first time they've attended, and I thank them for sitting through this patiently. Thank you very much.
Thank you, sir, for that informative lecture on physiology of acute pain. Moving on, we are glad to have our next speaker, Dr. MANJUNATHA PRABHU, who has served as a professor and HOD at Kasturba Medical College, Manipal, and now works as a senior consultant in Brunei. He is a renowned academician and has multiple publications in national and international journals to his name. His areas of expertise are airway management and regional anesthesia. We welcome you, sir, for our first interactive session on identifying life-threatening arrhythmias.
Okay, thank you. That's how I have been trained by Dr. Ramkumar and all his colleagues that time. So, it's my privilege to participate in this APGAP, and thank you very much to ANITHA, Malavika and the team, Shweta and all, for inviting me for this. First time I am participating in APGAP as an external person, in the sense not external to the Manipal anesthesia family, but external to the this committee of. My session is not as colorful as the first two, because it's more supposed to be interactive. So that's why I thought I'll not put colorful slides, but it will be more of black and white slides, and we have to get, I should be talking less, and you all should be telling me more. This is the place where I work now after 30 years of anesthesia in Manipal. So I'm in this place now. So we will talk about the identifying the arrhythmias that are life-threatening when we can come across them anytime. See, the difference is sometimes maybe some of these talks which are focused to the exam, whereas this talk is focused to your everyday practice of anesthesia. So you can get any one of these life-threatening arrhythmia any time during your clinical anesthesia service, or even when you are going in a traveling somewhere. I can tell one anecdotal event like that. When I was just going in I was working out in a gym. Working out means just doing some cycling, that's all, not very heavy. Suddenly I saw one sound by the side. Somebody who was lifting the weights, young man, he collapsed. This really happened in 2022 actually. So then we went there. He was actually lifting weight, he was doing treadmill, all that, and next moment he's fallen down, no response. So these kind of things, it can come in real life also. So it can be a real life scenario or it can be exam scenario. Luckily that gym was in the hospital only, our own hospital, so it was very easy for us to resuscitate him. So immediately after say an hour of resuscitation, then his question was, when can I come back to gym? That kind of, but of course he had a coronary artery which was a problem, which was stented immediately, all that. But scenario can be like that, as dramatic as like that, or it can be an old man with the ASA3 coming with usual hypertension, diabetes and renal failure. This is the combination we generally get in old people there. So they are coming with to your anesthetic, and whatever you say, they will think, okay, accepted. 100% mortality rate, that also they will accept. But at the same time, they know they are safe with you. So we have to do that part. Now coming back to identifying the arrhythmias, what we have to do is, first of all, we have to see what is the heart rate, and then we should see what is the rhythm, whether it is a regular rhythm or irregular rhythm. That is one of the important point we have to see. This I am trying in advance, I am telling you, because you have to do these things when it comes to subsequent ECGs. Is one P wave present for every QRS, not 2, not 0, 1 should be there every. And is the QRS is normal, because you know what is a normal QRS complex, what is the time duration, how it should be looking like. in a particular lead when you are talking about. And when we are talking about clinical monitoring during our anesthetic, it is generally 1 or 2 leads we will be looking at. We are not looking at all 12 leads. So, that is important. Is the rhythm is associated with hemodynamic instability. Most important thing you should remember, a sinus rhythm, there is no pulse oximeter not picking up, your end tidal is dropping in an intubated patient, then you have to be very careful. It may be sinus rhythm, like the Mahagurus of ACLS, Ramkumar sir, Krishna, all are there. So, they will tell you repeatedly that if there is no perfusion, whatever rhythm is, it is called as cardiac arrest, it is pulseless electrical activity, you can call it as. Once that those things are answered, then you have to see whether does the rhythm or arrhythmia require treatment. So, these are the points you have to look at. After that, I will go to straight away to the ECGs. During your preoperative assessment, you have to look at few things which are very important, because these are the ones if you ignore, you will be in deep trouble. Because what happens is, if you ignore them, you will not stress during the consent, you won't tell them what they can expect, and they will think you have not told them anything, they are totally safe. And if you have not recognized, you will not probably will be able to alter your anesthetic to the safety of the patient. It might not be safest because certain things may be unsafe in certain conditions. Now, when you come to preoperative, see this one, you can see there is a arrhythmogenic right ventricular dysplasia. These are some of the kind of conditions which are there in certain people. When you see like that epsilon kind of wave, QRS is wide. I am not going into the basic ECG where you should know QRS, what is PR interval, what is QT interval, T wave configuration, all that. So, in V1 to V3, the right chest leads basically, you have got a QRS widened, there is a epsilon wave and there is a T wave inversion and it is quite deep. Okay. This condition is called as arrhythmogenic right ventricular dysplasia. So, sorry, one extra opened, okay, fine. Now, I think this is one of the ECG which everybody heard about, right? It is very interesting, Brugada syndrome. Here you have code STA elevation more than 2 millimeter in V1 to again V1 to V3 leads, negative T waves. Look at the T wave, it is a really deep and big T wave. If you look at the QT interval also, it will be prolonged in this situation. These patients are also likely to have sudden ventricular arrhythmias. Okay. Now, I have to ask others, this is a quite common, who will tell me? Anybody raise your hand, someone? Postgraduates, not first 2 rows. Okay, you are sitting in 3rd row, not for 3rd row also, okay. Anybody? Simple, everything is written there. No, this is a small strip of ECG. I wanted them to just read it out so that they will wake up. Okay, let them warm up. This is another ECG. You can see here, what you see here is basically, suppose a patient comes to the trauma center, he comes with some other injury and then you are asked to take him up for a orthopedic, something they want to close reduction or something like that, very simple one. What do? Yes, patient will have other injuries, patient will have probably chest injury, but then if you look at it, there is a massive pericardial effusion. How do you diagnose with the ECG? So, you can see here, there is a low voltage QRS complexes alternating with a normal kind of waves, and that changes with the respiration also. So, there is a lot of low voltage QRS with the amplitude also changes. It is not uniformly low voltage, amplitude will also change according to the respiration also. So, in this situation you have to be very careful. If you give something, some drug like for example which is vasodilator, most of our inhalational as well as induction agent, that can make the patient collapse. Now, this is a ECG you will see in a neuro cases, okay. Sometimes looks very abnormal, okay. Huge T wave there and inverted T wave, and then QT is also prolonged obviously, because T is very wide, QT will be prolonged. So, this can be because of a intracranial hemorrhage. This is classical ECG of Wolff Parkinson, WPW, what we call it as a syndrome. There is a short PR interval and the R takes off little early. It is like a what is called as a delta wave, okay. And then we have got hypertrophic cardiomyopathy. You have a left ventricular. Keep these things in mind. Subsequent ECG you have to identify like this, okay. There is a left ventricular hypertrophy there. There is a deep Q wave. It is called as a dragger kind of Q wave. Hypertrophic cardiomyopathy. Many of this will come in subsequent slides. Be ready for this. Now, let us come to this. Now is the question. Now, unless you answer, I will not go further, because I do not have a end slide. So, I can end anywhere, okay, depending on the time. Okay. What is this? Who is going to tell me now? This is a young patient, exertional dizziness this patient has got. Other than that, there is nothing. Who will tell me? I have to identify otherwise? I can only identify the staff and the senior people only, because I was away for last 4 years, so I do not know many of them. Young looking, if I start identifying again, it will go to seniors only. Okay. Who is ready to take this? Easy one. Tougher ones will come subsequently. Otherwise, I have to convert it into a lecture. Yes. Yeah, just tell your name and tell me this.
So my name is Ajit. This ECG shows hypertrophic cardiomyopathy.
Okay. Can you tell me what you see exactly in the waves? Why do you say hypertrophy? LVH is there?
Yes.
Yes.
LVH.
Okay. How do you say LVH? Where?
The V5, V6.
V1, V5, okay. S and R. If you combine them, that is hypertrophic left ventricle. Left ventricular hypertrophy is there. Then what else is there? Yes, you only. Continue. You are doing well. You are doing good. Yeah, okay. You are looking at the monitor there. Okay. What else is there? Something like dragger going down. Where? And what is it? Sometimes you have to look at
V5, V6.
Okay.
Q waves.
Yes. Yes. Then AVL. AVL also there is a deep Q wave. Okay. So is this a ischemic? Yes.
Sir, in lead 2 and 3 STT changes, we can say ischemia.
Okay. Very prominent one you can say is LVH is there. You are right. Your first point is right. Then there is a deep Q waves are there. But compared to ischemia, there is a small change. These Q waves looks more normal like Q waves, in the sense it is a narrow, okay. Q waves are there in V5, V6 as well as AVL, okay. You can see here, all basically it is a Q wave only, and then you can also see Q waves in lead 1 also, okay, compared to your other waves, and V5 and V6 also, if you see, there are Q waves. So, this is not a ischemic Q wave, but this is because of a hypertrophic what? Cardiomyopathy. Okay. What happens is, the left ventricle here is hypertrophied. It can hypertrophy in different areas, the apical, outflow, many areas. So, what happens is, one thing is, it is already hypertrophic, it requires lot of blood to be fed, or the oxygen demand is quite a lot. So, you increase the heart rate, they are going to be in trouble, or you are also going to be in trouble. And then it also, because it is stiff and thick, it will relax also less. So, it will accommodate less. So, diastolic dysfunction will also be there. So, what you have to remember in this kind of patients is, you can't just induce like any other patient, give propofol 200 or something like that. You have to really look at them and monitor. If it is a major case, these are the cases where you should not think twice before starting a beat to beat monitoring of arterial pulsations. Okay? Yeah, hypertrophic cardiomyopathy. I have got couple of more slides of that if you want. Okay? This is the other one, hypertrophic cardiomyopathy. You can see the R wave. There is a clear cut kind of signs which suggest you of a hypertrophy. At the same time, if you look at the Q waves, there are deep Q waves here again. Okay? Lead 2, if you see, there is a deep Q wave there, and you can see, but these Q waves are again not looking like ischemic, old ischemic Q wave. This Q wave is again, it is a narrow, but Q wave is there. So, this is again a condition where is a hypertrophic cardiomyopathy. Why I am stressing these cases is, these cases may be young, this patient may be young, they will come to you pre-op. You have to, sometimes young patient, he says I am doing this, I am doing that, sometimes yes, I get little bit of giddiness, that is because of my, they will say ENT doctor said something or something, and then you think you ignore, but if you do not see these patients are the one who can collapse suddenly, they can have arrhythmias suddenly, and it is very unacceptable. The outcome which can come after that can be very unacceptable for you as well as to the patient, because they are young, they are so called fit, you can say, but this is the underlying problem. They say coronary, I have done coronary angio. Coronary angio will not tell you much in this situation. Coronaries are fine, but the demand is more stiff vascular, the ventricular muscles. So, dilatation is a problem. So, again this is another case of HCM. Voltage criteria, LVH, narrow dragger like Q waves. Okay. This is also again same one, I think not much of time, so I will pass through this. This is also another condition of HCM. I am not getting much response, so I am converting it into a lecture. So, this is a unique thing which is found mostly more commonly in Japanese patients, whereas this is a apical hypertrophic cardiomyopathy, and again you can see there is a very abnormal T wave. You can see in most of the places T wave is inverted in these patients, and they have a abnormal intramural coronary arteries with thickened walls. You can imagine intramural coronary arteries means what happens is, when they contract there is hardly any flow, unless they dilate fully, hardly any flow goes during diastole also. So, these patients again, they are likely to have arrhythmias and sudden cardiac arrest, which are difficult to resuscitate. Okay. Again same thing. Okay. This is a 12 lead ECG. This is in a patient where they have certain family history of sudden cardiac arrest in this family. Okay, some of the cases. So you can see the changes here. I have marked there. Okay, this ST is concave up. Same thing here. Again here you can see the most important. This is a unique thing you will see. There is a notch in the ST when it comes to V3 and V4 leads. This is Bundagard syndrome. This has been reported I think only in 2018 somewhere New England Journal it has come out. These are the familial kind of reports which has come from mainly 3 countries. I think it is mainly Denmark. Why I am focusing this is any of these things which are seen in the preoperative can have a lot of problem during intraoperatively suddenly, which we will not be able to tackle. This is reported in 2018. It is electrical changes which you see, which has been reported, and there is a history of sudden cardiac arrest in these patients because of arrhythmias. Okay, when they come to anesthesia, this can precipitate arrhythmia and then they end up in cardiac arrest, which is very difficult to resuscitate. This is very common. Is it? Yeah, now people should tell me. Common, uncommon ones are done. Even Sadashivan's daughter is raising her hand. So better somebody start, those who are anesthesia trainees. Yes? No? Hey, everybody, yes, yes, please. Yeah, see. Bradycardia. Madam tells bradycardia. Of course, I am not surprised because she is living with the person who is, we call it as maybe the Pitamaha of ACLS in Manipal. Okay. So, bradycardia, do you treat bradycardia or don't treat bradycardia? Who wants to treat? Symptomatic bradycardia. What do you mean by symptomatic bradycardia? A rate of, if you look at this, rate may be what? 1, 2, 3, 4, 5, 6, 7, 8. Maybe something around 36, 37. So, is it a bradycardia or not? Yes, bradycardia. Then if it is a under spinal, okay, symptomatic, if he says I am feeling giddy, blood pressure is low, okay. If it is under general anesthesia, what do you have to look? Pulse, definitely pulse. Okay. Then there is a hypotension. Plethysmograph will tell you lower perfusion. Okay. And most important thing you should never underestimate is end-tidal carbon dioxide. When you have a constant ventilation going, if the end-tidal carbon dioxide comes down, you should think of the lower cardiac output. Okay. So, if it is a symptomatic, you have to, what is the treatment quickly? How much? Which route? 0.5 or 1? Sorry? Which recommendation you are telling, depending on that? What is the latest? Latest ACLS is which year? Consensus? No consensus? Yeah, ACLS. 1 mg, yes. How often? How often? How often you have to give and how much maximum dose? Yeah, some chorus has come, but nobody has clearly told. Yeah, you can tell me. Yeah, you are. Yeah, go ahead.
3 mg is the maximum dose which we give.
Yes. How often you repeat? You said 1 mg. How often you repeat? 1 mg followed by 1 mg like that?
Every 3 to 5 minutes.
3 to 5 minutes. Yeah, 3 mg you can go up to that. If that is not working, you have to go for other agents which will produce which will increase the heart rate, like either adrenaline infusion or what else? What other infusion? Quickly, I have to go to the next. I am beyond time. Isoprenaline. Who is for isoprenaline? Okay, okay. Okay. Yeah, you have to go for if atropine is not working, sometimes you have to go for other agents which will increase the heart rate. Okay, this is a very simple again. Who will tell me first? Sinus or non-sinus? Sinus tachycardia. Okay. I think, yeah, in this what you do? Again, symptomatic, asymptomatic. If it is asymptomatic, under anesthesia, you remember one thing, what you have to do, most important thing is you look at whether you are given relaxant before, you are given enough opioid, you are given enough depth of anesthesia, whether the surgeon is doing something tricky, all those things you have to look into under anesthesia. And if it is with the hypertension, you have to deepen anesthetic, maybe opioids, all those things. If it is not associated with hypotension, then you have to worry about this. Okay? I want to show one, okay. Yeah, anybody want to take this or maybe, okay, this is a SVT, I have crossed time, sorry, I will go further. This is atrial ectopic. Sometimes you have to be very careful when this comes, atrial ectopics, when this comes you have to be careful because it will be telling you something underlying acidosis and the extreme of condition. Recently, I have seen one of the case where it can be one of the sign even in case of a impending pulmonary embolism also, embolization also can have this. I saw one, I will just show that case maybe later. So, you have to be very careful when you have a atrial ectopics coming repeatedly. You should look for, like how you see Hs and Ts in case of a pulseless electrical activity, you should look at here what are the causes, not necessarily those Hs and those Ts, it can be something different also. Okay, this is the patient who came for a cranioplasty, simple little 57-year-old 61 kg man who came for a cranioplasty. He had a tracheostomy also, so we did not have a problem. This is his ECG. Quick identification, spotter. Yes, 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 yes. First, look at this, not regular. Look at this, not uniform amplitude, atrial fibrillation. Okay. But if you look at his other parameters, BP is okay. See, all these are okay. This is a tea time. No, I am eating into tea time, right? Discussion is, this is supposed to be discussion, they are not discussing. Okay. Oh, for the other two also. Okay. So, this patient later, after intubation, this is what happens. So, are you worried? Why you are worried? Yes, tachycardia with the atrial fibrillation, you are worried about hypotension, but this patient gives this pressure. Same patient, okay, 159/95. That means there is a, you have done some stimulus. Actually, neurosurgeon has positioned by that time, I think, yeah, in the previous one, yeah, they have taken 1 hour 13 minutes since we have initially started because shaving and so many other things. So, when you positioned, then it came like this. Okay. So, this is what it happens. So, what it requires? Yes, you can give beta blocker to control the heart rate, but here blood pressure is also high. You have to deepen the plane of anesthesia also, because his heart is telling you, I am not satisfied. Okay. This one, unifocal ventricular ectopics coming after every regular. So, this is a bigeminy. This one, yes. Okay, what do you do? What is the first step? Check the pulse. Yes. After the pulse, if there is no pulse, treat it as ventricular fibrillation. If there is a pulse, yes, cardioversion. I think I have to go on. Okay. This one, R1T phenomena. Okay. Torsades de Pontis. You can see the changes. What is the treatment which is not used in others? Magnesium. Yes. Also, you have to increase the potassium level also in this patient. Yes, magnesium is the treatment. This one, depending on what amplitude you have taken. If it is a high amplitude, sometimes even ventricular fibrillation can look like this. This one? Okay. Signs of PE. This patient, okay. Sometimes signs of PE can be only, you might see the tachycardia, right bundle branch block and T wave inversion, only that can be initial thing. Then I have couple of more PE kind of this one. This is a bilateral PE. So, if you have M pattern in V1 and also kind of a W kind of pattern in V6, see like this, R dash, these are all signs of right bundle branch block. So, in case of pulmonary embolism, there will be right bundle branch block features will be there will be strain will be there on your right side leads. Basically, it is a problem for the right ventricle, left ventricle is not receiving much, so not much of problem. So, I think I will stop here because it is going too much beyond the time, sorry. Okay. So, this is about P. I have put some kind of points for P. Basically, it is a right bundle branch block, what you will see. Right ventricular strain pattern, right axis deviation, dominant R wave in V1, okay. Right atrial enlargement P pulmonale, sometimes you can see that. And most important thing is S1, that is S in lead 1, Q3, okay, Q wave in 3 and also T3, T inversion. So, these are the things you have to look for. And atrial tachycardia, atrial fibrillation, flutter, all this can come in case of pulmonary embolism. So, this you all have this in your ACLS. So, I am not going to go in detail. Adult bradycardia, what is the treatment, and adult trachycardia, and this is the mega code kind of thing, and cardiac arrest. So, I think I will stop there because it became again a lecture, but I hope most important message what I want to tell you is ECG is just an indicator, it will tell you something is wrong, but what you have to do is you have to correlate that with many other things and then you build a story and then you realize what is happening and then you treat the patient. Never treat the ECG, treat the patient. That is why sometimes if a fit man, young man, no other problem, heart rate is 32, still I withhold giving atropine because later heart rate will go up. So, I do not want to give atropine if his blood pressure is also okay. You talk to him if it is spinal, if it is GA you see the other parameters. Okay. So, treat the patient, look at the other symptoms, most important pulse oximeter, the blood pressure, capnogram. Okay. Look at that and treat accordingly. Thank you.
We shall now be taking the queries for all the 3 sessions. I request the speakers of the previous 2 sessions, Dr. ANITHA SHENOY and Dr. SADASIVAN D IYER, to join Dr. MANJUNATHA PRABHU on the stage.
I think I have asked too many questions.
The topics are open for discussion.
I expected that you would go along the usual way of dealing with life-threatening arrhythmias, tachycardia, bradycardia and everything. It was a totally different kind of talk. But then for the postgraduates, I think you should also remember the first slide that he put. First thing he said, what is a heart rate? Is there a P wave? Is there a QRS complex? Is every P wave followed by a QRS complex? And it's regular? And is there a hemodynamic instability? I think that slide is something very, very important for all of you to remember to diagnose an ECG. Correct, Manjuna?
Yeah, I think I agree with you. And other most important, why I spend little more time in the pre-operative, because that is the one, if you miss, you are in a soup. In the sense, it is very difficult to tell the patient later that a ECG which was there I didn't see. And then I ended up this. There are a lot of anecdotal things I can say. Recently we had one patient who came for very simple thing, gastroscopy. Gastroscopy is we give little bit of propofol, they will sleep, and then they didn't come with a whole lot of files, and we hardly do pre-op also because it is a 10 minutes procedure. You give 2 small doses of propofol, they will sleep, and then they say it is done, and they will wake up. But then, because the person who was doing it was experienced, he thought something is not right, something is not right. Then he went on probing. And these patients, sometimes they are trained somewhere by somebody, I don't want to point out who, that you say nothing is wrong, other than the surgical or whatever. They will say nothing. Walking, talking, yes. When did you? So then, when you really look at it, that person was not happy to give propofol to this patient. And then he called all the records. The gastroenterologist got irritated because he wanted to do 10 minutes job and collect that whatever money, because it is a private setup kind of thing. So he was not happy, but luckily the person who was doing the case was not me, so I didn't compromise. He said, no, you have to wait. And then it was found out to be that patient had a tight mitral stenosis. And what happens in some countries, depending cultural, all those things, we don't go and auscultate all the time. If there is no positive history, that is a bad thing, I agree, but it's not very easy sometimes. Somebody walks in the OPD and they say want to have a gastroscopy. And that patient had a mitral stenosis, had a cardiac failure a couple of months before. And then if he had not seen it and given a sleep dose of propofol, then he would have been resuscitating for next whatever time, if it is successful. So that kind of situation, that's why I want you people to focus on pre-operative assessment most importantly. Okay? Best time, I think, I still appreciate the way Ramkumar sir was going for his pre-op assessment when he was staff. Personally, he used to go. So that you will pick up something which is not told you by the surgeon or by the physician or by the records or by the patient. Then that is very important. That because for you it is real. For them it is only report. For you it is the patient who you have to take him through the procedure and whatever surgical problems which can come. There are a lot of surgical problems also which can come. I didn't include all those things, but then should remember pre-op assessment is very, very important. Intra-op changes can occur. The patient which I said PE, that was having a hip fracture, 90-year-old Japanese patient, all that. But then that patient developed PE intraoperatively. Yeah, it is expected, probably. But then this happens. But pre-op, you cannot miss. If there is something which you missed, major thing, that I would say it's kind of sometimes it can become criminal kind of mistakes. Okay? Be careful.
So just small queries. Just to add what Manjunath sir was saying, I'm sure all of you may have this situation where you will have a surgeon sending a patient to you. Quick procedure, give short GA. Short GA, very wonderful terminology, right? Right? Short GA. I work in a very busy corporate setup where time is money. So you have to be quick, right? So they many times don't even wait for you to properly evaluate your patient. But please, that's what I tell the surgeons. There is nothing called short GA. It is GA or non-GA. You're doing regional, right? So either ways, no compromise on pre-op evaluation, right? That extra 5 minutes that you spend with the patient will ensure that the surgeon is doing the procedure in a short time with your regular general anesthesia.
Yeah, I think we are just a minute from the closure time for this session. And Sada, to end on a joke, you're the last person to give a short GA. You're the tallest anesthetist around. I don't think you can give a short GA. And it's an extremely proud moment for me because all the three speakers of this session were my students, and I think I can't have anything better than that.
I'm very sorry
No.
to disturb you. Please. Sorry to disturb you. I came late. I don't want to do any academic things. The name APGAP, Anesthesia Postgraduate Academic Program. This should be a two-way traffic, not one-way. Right? I am very sorry when Professor MANJUNATHA was asking, and I was not there the earlier lectures, but people are not coming forward. You must have come from all the way from the different places, right? To learn, not just to listen. And nowadays, knowledge is available, material is available, right in your hand itself. This is two-way traffic. It should be and must be. Please, and this is the beginning of the 3 days program, and please do that one, right? I am Hanumantrao, anesthetist from Guntur, but I was here in Kasturba Medical College. And the thing is, funny, right? He will never accept the silence from the students. Right? These two things, please keep that.
I now request Dr. Malvika, our HOD at KMC Manipal, to kindly come forward and felicitate the speakers.